reliable.
Okay, thank you. So again, to thank Joint Fiscal for coordinating and helping us put the meeting together again. And we're just going to, I really don't apologize. We're going to move ahead now. And we found out that there are several different ways to use this acronym creatively, so it makes us feel good about what we're doing. And so Pat and Wendy, thanks again for being here. We each have our slides. Why don't we hand it back to you and go forward with a description of the Advancing All Payer Health Equity Approaches and Development Model.
Thank you again for, for really hanging in on some pretty complex material. So what I want to start with is, and again, for the record, Pat Jones, Interim Director of Healthcare Reform for the Agency of Human Services. I want to start by sharing the timeline with you. Again, on November 16th, the Center for Medicare and Medicaid Innovation released a notice of funding opportunity for the AHEAD model. There's a link there to their website, which has quite a bit of useful information. States that wish to apply for cohorts 1 and 2 have until March 18th of 2024 at 3:00 p.m. To submit an application. CMMI has asked for, they're encouraging states that are planning to apply to submit a letter of intent, but it's not required. That deadline would be February 5th, 2024. As I had mentioned this morning, there are 3 cohorts that they're envisioning in the model. And, they vary in terms of either when they have to respond to the NOFO, when the model would be implemented, or both. So cohort 1, the response to the NOFO, again, is that March 18th date. And there would be, once CMMI selected states, and they're talking about for that time frame that they would make a selection in May of 2024. And so there would then be, a pre-implementation period where, negotiations for state agreement and other things would be underway. And that would last 18 months for that first cohort of states. So again, the earliest implementation date there is January of 2026. For cohort 2, same time frame to submit the application, but quite a bit longer on the pre-implementation period, with the thought that some states might be more ready than others to implement such a model. So they wouldn't start with implementation until 2027. And then for cohort 3 states, they would have a little more time to respond to the NOFO. I think it's August of this year that they would have to submit an application of next year. And sort of in the middle pre-implementation period that would again have that starting in 2027. You'll notice for those cohort 1 states that there's a nine-year performance period for this model. That I think they've learned something from these complex models. As I mentioned this morning, our model was initially 5 years. We extended 2 more, and there's a potential that we'd extend through 2025. So I think they're realizing that models of this complexity and talking about the kind of transformation that you're really talking about in our healthcare system take more time. So 9 performance years for the cohort 1 states, 8 for the others. So this model goes, from now through 2034. They have indicated that there will be, that they will select up to 8 states. And it can be a sub-state region. The states are the applicants for this model, but they don't have to apply for the entire state. They can apply for of the state. So there will be up to 8 awards, no more than 5 for cohorts 1 and 2, because they want to save some spaces for cohort 3. So there would be at least 3 slots for cohort 3 states. So next slide. So this, I wanted to really pull language from the NOFO itself to be really clear about what the goals of the AHEAD model are. So the way they depict it is it's a voluntary, state-based alternative payment and service delivery model designed to curb healthcare cost growth, improve population health, and advance health equity by reducing disparities in health outcomes. So again, that centrality of health equity, it's a little different than the triple aim that we talked about this morning, which is, reducing healthcare cost growth, improving population health, and improving the quality of healthcare. They really, for them, quality of healthcare really means equity in healthcare and reducing those disparities in health. So it's a little bit of a different take on the AAA, but really the same types of goals that we've been focused on here in Vermont for quite some time, and that people have been focused on national. So this next slide, I have sometimes been told that it's like too much, but it's actually the best way it's CMS's slide, but it's the best way to describe what this model is in one picture. And so I will do my best to explain, but I really think it works. So, again, they are looking, they're calling it a flexible framework. I'd say there's some flexibility, some, more directive parts of the model, but they want to improve health outcomes across multiple states. So each state that participates in this model will be required to be accountable for a number of areas. And they're listed in that gold box. So this will be part of the state agreement. The signatories on this model will be similar to the folks who signed the last model. But the first area of accountability on a statewide basis is total cost of care growth. And they will look at both total cost of care growth for the Medicare fee-for-service population, not Medicare Advantage, but Medicare fee-for-service. And then they will also look at total cost of care growth across all payers. We have that in our current model, so we're pretty familiar with total cost of care as a measure, how to calculate it, and so forth. The second area, and this is a new focus, and it really speaks to some of the data that Chair Foster presented this morning and some of the key elements of this model. But the second thing that states will be accountable for is essentially growth in primary care investment. So they, again, will look at that from the Medicare fee-for-service perspective, and from the all-payer perspective. So that is not something we have currently in our model, but it is work that you all have requested and that the Green Mountain Care Board has collected data on in the past. Vermont has been part of a consortium of New England states that have worked very hard. Rhode Island has actually been a leader in this area, but it's worked very hard on measuring primary care investment and doing so in a way that's comparable. And we believe that CMS is going to lean on that work pretty heavily. So that's new. And then the third area is equity and population health outcomes, on a statewide basis. And we have as I mentioned this morning, a quality framework in the current model, but that equity lens is a new accountability for us and an important one for this model. So that's what the state, when it signs that agreement, among other things, will be accountable for if we were to move forward with this model. There are three components that CMS outlines as really being key to this model. The first is what they call cooperative agreement funding, and that's funding to really help start up and implement the model and, help prepare for what needs to happen. I will tell you that it's not an enormous sum of money. They are talking about giving states up to $12 million to be used during the first 6 years of the model. So that's a total of $12 million to be used over 6 years. And, we're a pretty small state and, that still seems like not a ton of money. But, I think they see it as an effort to support some of the significant work that would need to happen in order to move forward with this model. The second component that we've mentioned before and is really key is hospital global budgets. And they're talking about, at least initially, hospital inpatient and outpatient services. And then the third is what they're calling primary care ahead. And then they outline a number of strategies that they are, proposing in the model that they think will help states achieve those accountability targets and will help really inform those components. The first, again, equity integrated across the model. So you'll see, throughout measures needing to be stratified for equity for different populations, identifying where the disparities in health, how, ensuring that there's a plan, a statewide health equity plan to address those. Second area, what they call behavioral health integration. We tend not to use that term in Vermont, so you'll see us trying to indicate that on some of these slides, but mental health and substance use disorder treatment integration, particularly in primary care, but you'll see it in the hospital budgets and so forth. What they call an all-payer approach. Heavy focus on Medicaid being at the table from day one in this model, and then commercial payers by year two having at least one commercial payer involved. Ideally, over time, they'd like to see all payers involved. But that's a heavy lift, but they definitely are seeking that. Fourth, Medicaid alignment. And you'll see that both in the hospital global budget components, and you'll see it especially in the primary care component. And then fifth, they articulate a strategy of accelerating existing state innovations. And as we talked about a bit this morning, I think there's some areas where that can, the model looks like it'll realize that. There are other areas, a state like Vermont that's been working in this space for a long time. We may feel like we're being held back a little, but it's at least aspirational that existing state innovations will be accelerated in this model, that will build upon some of those. And a lot of the feedback that we gave them was on that very point. Let us keep moving forward on things. So I hope that it's a very busy slide, but it is a way to say, there's these statewide accountabilities, there's these key components, and then there's these strategies that are infused throughout the model. So our way of sort of trying to simplify the 127-page NOFO is to say, okay, when we look at that NOFO, what are the components? And so we'll speak to most of these. A couple of them we'll kind of hold off on a little bit, but again, it's a statewide accountability targets, but also provider level. They're looking for accountability targets for hospitals and for, quality measurement for primary care.
I have a way back question. I'm sorry, I didn't ask way back. This whole shift, but I'm realizing I keep on getting stuck on the question inside my own head from listening to you, so thank you. This shift to having it be a multi-state agreement rather than a single state agreement, what does that actually look like? Are you pre-brokering relationships with other states, or are they brokering relationships with other states?
I'm looking for Sue. She asked the same question at lunch, and this is now.
It seems like a really important
This is
detail.
the third time I gotta fix the slides on this. When they say multi-state, what they mean is that right now, Vermont has its own all-payer model. Maryland has its hospital global budget model. Pennsylvania has a whole different model that's a rural health and rural hospital model. And so when they say multi-state, what they mean is that they want to put a model out there, and they don't want to do these one-off models. They want a model that multiple states can participate in, but we don't have, we're not going to have to, our total cost of care accountability will be Vermont only. If we do a specific Vermont-specific hospital global budget methodology, it'll be for us. We don't have to combine.
So the ahead model is the multi-state model.
The ahead model
as long
is yes.
Communicate with them in keeping with what they've described in the ahead model, then we are meeting the multi-state model.
Right,
right. Thank you.
It would be, the better term would be a model for multiple states. It's not like it's not like states band together on this. So thank you for asking. I literally just got asked that question at lunch, and it's not the first time we can ask. So, okay. So, again, these components, not only statewide, but they're also provider level accountability targets. We're trying to use the language hospital global payments rather than hospital global budgets because of the hospital budget process that the Green Mountain Care Board has. It just, we feel like it's more descriptive and less confusing. Primary care had the cooperative agreement funding. That Wendy will speak to the model governance structure that's laid out in this model, as well as health equity. And then alignment between Medicaid and commercial payers. And there's some information in the NOFO about expectations around statewide data and health IT infrastructure. So when this keeps evolving, but when we had a different version than we saw the NOFO, we've added a couple boxes. But these are the things that we really have to respond to in the proposal that we put forth in an application. So we'll take them, one at a time and see how far we got. So this again is a CMS slide specifically about hospital global budgets. It describes what they are and how they are really, the global budget will be based on historical Medicare revenue and really on inpatient and outpatient care. But there'll be some adjustments to it. And they will adjust for things like inflation. They'll adjust for things like demographic changes, to Senator Kitchell's point earlier, an aging population would be considered. And then there might be points where hospitals change their service lines. They might start providing a whole new service, or they might stop providing a particular service. So some kind of mechanism to adjust for that as well during each performance year. And then here's that statement that I had called out earlier around, how the aim is for hospitals to be supported in transforming care delivery from, acute services to primary care and community-based services. So that, that aspirational goal of let's shift the balance in how we provide care. They have identified several incentives that they think will encourage hospitals to participate in this model. The first is that they are, for the first 2 performance years, if a state joins a model, for the first 2 performance years in the Medicare version of a hospital global budget, they would provide what they call transformation incentives. And they're talking about 1% of those total Medicare revenues that would be provided to hospitals to help transform care. They speak to the things we talked about earlier, which we've already experienced here in Vermont in our current model, but that financial stability, the predictability, and I'll add flexibility in receiving funds and in how they can be used. There's some, ability for hospitals, if it's not being reconciled back to fee for service, and there's sharing in the savings. Say there's been, some efforts to reduce avoidable utilization or some efficiencies that have occurred. Those are things that hospitals could share in the savings. There's a bonus for improvements in health equity. So if hospitals are able to make some gains in some of those measures around health equity, then they could get a bonus for that. We had mentioned, and Wendy will spend a little more time on this in a bit, but those Medicare waivers, there's waivers in Medicare rules that can change how care is delivered and engage some of those home and community-based service providers, the non-hospital providers in care transformation. And then they indicate that there'll be some learning opportunities that hospitals can participate in as well. So that's what they see as the incentives for hospitals to join in this measure, in this model. This is for folks who like words more than pictures. That would be me. This is an effort to try and summarize that a bit. Some of the key elements. So, the first is think of these hospital global budgets or payments as prospective, predetermined amounts. And this is what CMS is saying is going to be in their methodology. And it's going to be inpatient and outpatient services only. And it'll be based on that historical spend with some annual updates. And I want to just note that, our current model, there's a prospective payment, and it covers more than inpatient and outpatient services. It really covers what we think of as our Medicare Part A and B services. So it includes professional services, office visits, home health. So, right now we have a broader definition of what is included in the total cost of care. And in our current model, those prospective payments. Again, you'll see this for, the focus on equity, but they want to adjust hospital budget or payments based on social risk and quality. So if a hospital is serving a more vulnerable population, the intent would be to provide resources to meet their needs. And again, there will be that bonus for health equity improvement and the transformation incentive adjustment to support some of those more care coordination or preventive type services. And then, there will also be adjustments sort of later on in the model around the hospital's total cost of care. So remember, there's that statewide total cost of care, but there's also the hospital level total cost of care. And they'll be expected for the folks who are in their service area to, to reduce growth in those costs. And then also for effectiveness around avoidable utilization. So those are the ways that CMS is saying they're going to adjust. The shaded box is what really gives us the ability to say, that's great, thank you, interested in this, but we might want to do our own thing in Vermont. We might want to have a more tailored hospital global payment methodology. And it's the information in that box where statewide rate setting, hospital global budget authority, experience in value-based care. Those states can develop their own methodology as long as it meets some of CMS's principles, and they would clearly have to review it and approve it. So that's been a focus of the work of that hospital global budget technical advisory group. And it looks like we have a question from Senator Kitchell.
Oh, yes. On your prior slide, this sounds so good conceptually, but it seems like a lot of what is plaguing our hospitals right now are more externalities, such as what is happening in long-term care, the problem with nursing homes, those patients getting backed up in hospitals, not because of policy or design or intent or will, but by default, are ending up, and certainly with the mental health patients that have plagued the system for a number of years. So I'm just wondering how you see, in other words, the hospitals are only one piece. And so as you're looking at this, how do we design or assure that the resources for the hospitals to carry out this, role, in fact, they don't get forced into care simply by default, not because they're anxious to do it or feel it's appropriate to do it, but it's ending up on their doorstep. So I was just wondering, in light of past experience, how we think about the hospital role in the system of care and all the other pieces that ultimately influence what hospitals confront.
As an example, workforce issues that are outside of the whole arena we've been,
certainly that would be
externality.
But it wasn't just workforce. I think, as we were looking at the shutdown, or with the loss of the state hospital and then the creation, we had some major capacity issues in that part of the care system as well. So workforce exacerbated it, certainly. But I was just wondering, is there, I guess what I'm saying is we need to make sure as we're looking at this, we understand all those other component pieces within our care delivery system, how they can either support, complement, or actually be problematic to where we want to go.
Yeah, thank you for that question. It's one that comes up all the time. And it's something that we're going to have to address in an application and subsequently in a agreement if we are selected and we decide to move forward. I can tell you that it is a key priority at the agency. The secretary is deeply engaged on those issues. This morning I had talked about the short-term stability work group that had met, and that was a clear focus of that work group as well. And we came, there were some ideas that we came up with. We've implemented an alternative payment model for the Brattleboro retreat, which has helped. So it took some time. It didn't happen right away, but it ended up resulting in some additional capacity there. Skilled nursing facilities. there are some challenges there. Home health, there are challenges. A lot of it's workforce. Some of it was pre-existing capacity issues, as you suggest, that, even before we had the workforce crisis, inflation, a lot of which is driven by workforce, but not solely. And hospitals have been very articulate about what it means when they have patients who really need a different level of care, and there's nowhere for them to go, at least immediately. I don't want to open this gigantic topic, but the housing situation is another concern. But I want you to know that we are thinking about that. That is much of that is the core work of the Agency of Human Services right now.
Social determinants overall.
All those social determinants, that's right, we are heavily focused on, the short-term stability subgroup came up with a number of, I think it was like 22. Yeah, recommendations for what are things that we can do, and some of them are being implemented, like the eye care, long-term care facility for people with very complex needs. I mean, I think that was going to happen anyway, but it was really that was highlighted as an area where we could build capacity. It is going to take a multifaceted, all hands on deck effort. And we have to try and articulate, and we have articulated to CMMI these challenges, but we have to try and articulate that in a proposal that we put forth, that there is need to resource some of those areas, whether it's medical respite, whether it's long-term care services and supports, whether it's mental health, both community-based and facility-based. We have to have adequate resources, or it's not going to result in the desired outcome. And those are equity issues too. So it's not, I can't give you we can fix it, but I can tell you how to fix it, which is that we've all got to keep doing the work that you all have been doing, that we've been doing together. So that, what I just outlined on the last slide was what CMS is saying about their methodology, plus this ability to do a state designed methodology. This slide goes into a little more detail on what we think some of those principles are that CMS is going to use when they look at a state designed methodology. So, some key points. One is that they want, these global payments to move away from volume-based, i.e. fee-for-service reimbursement, and, hopefully reduce any unnecessary utilization that might be happening out there. At a minimum, they're saying that the state design methodology will have to cover inpatient, outpatient, and emergency department services. But, the news there is that there's an opening to expand beyond that in similar fashion to what we have now in our model. They say that it needs to allow participation from short-term acute care hospitals and critical access hospitals at a minimum. I think, they're talking about this level of care called long-term care hospitals, which we don't really have here in Vermont, but they definitely want the safety net providers in this, including critical access hospitals. They want to see that total cost of care accountability for hospitals in a state design methodology. They want to see quality adjustments that are, tied to the CMS has a bunch of hospital quality programs. And so they want to see some quality adjustments. They are indicating, though, that there might be a little flexibility on what measures are selected. And they want to see equity adjustments as well. So, and they're talking about a bonus for equity, but they want to see some kind of a element in a payment methodology that recognizes equity. They want incentives to recruit and retain hospitals early on. So they've put forth that transformation incentive adjustment. It sounds like, there might be some flexibility if we want to do that a bit differently. Medical and social risk adjustments have to occur in the hospital global budget. So, adjusting for both of those categories, health status and health-related social needs or social risk. That those adjustments for population growth, demographic changes, let's, talk about aging again, and other factors, there has to be an element of that. There has to be the methodology would have to consider changes in service lines, inflation, and other types of typical shifts that you might see every year. And then they, again, with that interest of getting the safety net providers in, the critical access hospitals, there can be some kind of a risk mitigation for them, but they do not want the budgets to be reconciled back to critical access hospital costs or fee for service. So they want it to be a true global budget. This is the amount of funding you get. So those are the things that we know. And, they sound pretty familiar. They sound like, there's nothing that I think causes panic in here when we think about a state design methodology. So that's hospitals and hospital global budgets. We'll probably spend the whole 2 hours on that, but let's move on to primary care ahead, because there's a lot of really interesting information around this as well. So I'm kind of relying on the CMS slides here because I think they're actually pretty good. But they've outlined here that there are, 4 main goals in the primary care ahead program. The first is that they want to see that increase in primary care investment. So that, again, is a statewide accountability. And, based on the data that we saw this morning from the Green Mountain Care Board, there's room to grow there. They want payers to be aligned. And I want to spend a minute here because I think this is a significant part of the model. Whereas, and others may disagree with my interpretation here, but whereas with the hospital global budgets, CMS is sort of setting the pace here and saying, these are the principles we have. This is what we want to see happen. Yes, you can have a state design methodology, but we've got some pretty strong parameters there. In this case, they are really talking about Medicaid taking the lead here. They are requiring that if a state applies that they need to have a Medicaid, some kind of an advanced primary care model for Medicaid. And that what Medicare wants to do is to provide some financial resources and support, but they want to sort of sit at the table with Medicaid, and they want to align with Medicaid. And to me, that is excellent news for this state because we, some states don't have a Medicaid advanced primary care model. We not only have a Medicaid advanced primary care model in the form of the blueprint, but we have commercial insurers participating in that model as well. So it's multi-payer. They're looking to let the states lead on that. And similarly, a goal is to not only align payers, but to support advanced primary care. And they talk about things here like mental health and substance use disorder integration, care coordination, looking at health-related social needs. These are all things that our primary care practices have worked really hard on as part of their efforts in the Blueprint for Health. So to me, this is one of the most encouraging things in the model.
Just to interject a thought, and don't need to respond to this, but as you were looking at incentives, for example, and talking about improvement from where we are or where we can get to for hospital participation. And then you're talking about some of these things that we are already doing. So it may be that we have a shorter distance to go for perfection than others. So how do we get rewarded for the work that we've currently done? I will just leave that as a question. Because we're consistently not rewarded for the work that we've done in Medicaid and other areas, at least in terms of resources. So I'll leave it there, but it continues to be a problem.
I think when we get to, it's either the next slide or the slide after that, I'll speak to that for a moment.
Okay, thank you.
Some resources that Medicare is putting into the game that could be helpful for us. And then sort of finally, they want to see broad participation. What they mean by that is they want to see critical access, FQHCs, and they want to see rural health clinics involved in smaller practices, independents, and so forth. They don't want to just see hospital-owned practices. They want to see a broad set of primary care providers. We had mentioned earlier that under the current model, we have the comprehensive payment reform program that OneCare does, our program that's a capitated payment that the 19 independent practices are participating in. They are not doing that for 2026, and that's a disappointment and a concern for primary care practices. They are saying, we want to do that, we want to get there, but we can't do it for 2026. Let's think about 2027, and they've already invited us to communicate with them, early next year around, and we've shared a ton of information about what that program looks like. Let's just put it this way, CMMI, when you say Vermont and CPR, they know exactly what we're talking about. So that's a concern because you've got these practices who have been doing this. You've got, also your hospital-owned practices. We're getting, sort of all-inclusive population-based payments for them. And then I had mentioned that merit-based incentive payment system, the MIPS issue with the reporting. We don't have to report. Now, FQHCs are exempt from the MIPS program, but for our hospital-owned and independents, they haven't had to do that reporting. So if we can't make headway on that, that's a problem. And we have articulated that over and over again, that this is a big concern if they want primary care in. Now, there is a payment model that might help entice folks for sure, but it definitely is disruptive and makes it challenging for primary care. So while there's some encouraging things, there's some things that aren't in here that we wish were. So next slide. Yeah, so this is the payment model. So what CMS is saying is that they'll pay, Medicare fee for service, for some practices continue that, for practices that are capitated, sort of go back to fee for service. And then in addition to that, they're going to provide an enhanced primary care payment. And they are saying that will average $17 per fee for service or traditional Medicare beneficiary per month, not for Medicare Advantage, but for the Medicare, regular Medicare beneficiaries. So it's an average of $17. There will be some adjustments to that. It won't go below $15 per member per month, and it won't go above $21. But that's a fairly significant, investment. And, again, this all folds into that desire to see increases in investment in primary care. The requirements that the practices have to meet to, participate in AHEAD, if they want to participate in this Medicare enhanced payment and the AHEAD model, they also have to participate in the state's Medicaid advanced primary care model, or they use the example of a patient-centered medical home model, which is exactly what the blueprint is based on. Now, again, when you say we're this close, this is a place where we are this close. Some states don't have such a model. If they do have such a model, they might not have a huge participation. Here, most of our practices participate in the blueprint, our primary care practices. So it does feel like, we're in a pretty good place on that. So that's really significant. That's what I mean when I say it's like they're letting Medicaid lead or letting the states lead, because what it's really saying is we're going to offer up this enhanced payment. We'd love for you to be involved. But for you to be involved, you need to also, to make this a multi-payer thing, you need to be involved with your Medicaid program as well. And of course, here we have Blue Cross Blue Shield and MVP and Cigna also participating in that, in the blueprint. So, and then I'll share a little more about this in a minute, because it's just so relevant to the work that you did last session on the blueprint pilot, but I'll share what their care transformation requirements are as well. And again, they want to see that aligned across Medicaid and Medicare. And then they talk about what do you do with this enhanced primary care payment? And this sounds pretty familiar too. A practice can use it to invest in infrastructure. They can use it for staffing to do that advanced primary care. And so again, it's care coordinators, mental health and SUD staff, community health workers. These are all the types of things that we talked about last session with the blueprint expansion. So in a way, it's sort of fuels or jump starts work that we're already doing by having Medicare really commit some resources to this, because they've supported that $9 to $10 million that we talked about this morning. They've been supporting, but not to the level that Medicaid at all, and not to the level that the commercial insurers have been supporting this work. So it really kind of gives a little extra fuel to those efforts. So, eligibility criteria for primary care practices, it is voluntary, but, some of their models are more limited as to what types of primary care practices can engage. But here they're talking about FQHCs, rural health clinics, primary care. Again, they have to be participating in, the Medicaid program. There is one requirement that hospital-owned practices can only participate if the hospital itself is participating in the global budget component. So that's definitely an eligibility requirement. There is an exception to that, and it's literally a response to a question that Vermont specifically asked. We have a couple hospitals at least that own rural health clinics. And so we asked, if a hospital owns a rural health clinic, does that hospital have to participate in order for the rural health clinic to participate in primary care AHEAD? And so CMS went back, CMMI, and worked through that and came back and said no. For rural health clinics, I don't know that there are hospitals anywhere that own FQHCs, but if there are, this would apply. But in our state, it's hospitals owning rural health clinics. And so, we have the Gifford situation where the, FQHC sort of is over the, the bigger organization. But, but it's for rural health clinics, they can still participate even if their hospital isn't. So that was kind of interesting. So this is the transformation slide, and this is what they're saying will be required of practices, although like the circles are requirements, but the boxes might be more examples. But again, this is going to sound real familiar to you all, but they're saying that, what they want to see primary care practices do in this model is focus on health-related social needs. And there they're talking about screening for health-related social needs, social determinants of health. Again, identifying and strengthening those relationships with community resources and those organizations. And you can think of your community-based organizations and your long-term services and supports providers and so forth to address those social drivers of health. And that's a lot of the work of the community health teams, some of the ACO work. We've been doing this. We've been at this for a while here in Vermont. And then incorporating some of those staff members who can help address those social needs, social workers, community health workers, others, to really help with that coordination. So, sounds like stuff that we've been doing. And then for mental health and substance use disorder integration, talking about reporting on some of the quality measures that relate to mental health and substance use disorder treatment, some warm handoffs for mental health and, like as part of the expansion, if there's, embedding of mental health and substance use disorder treatment providers in a practice, that makes a warm handoff all that much easier, as well as those relationships with community organizations. And then they give the example of managing medications for people with complex mental health conditions. And then for care coordination, the examples they give are more focused on specialty care, that coordination between primary and specialty care. But that's what they're talking about in terms of care transformation. So that's primary care ahead, in an overview. And, I'm going to move on to the accountability targets. And I have, we had in the appendix to the slide deck, there's specific information from the NOFO on what they're thinking about quality measures, because some people like to geek out on quality measures. And so I put them in there because it's often, people are curious about what are they going to measure? So, again, they're like saying, these are what we're thinking, choose one from this category, you have to have one here. But they are also kind of implying that there might be a little flexibility. I'd say there's a decent amount of overlap between things that we already have been looking at in this state under the current model and others. So I'm not going to dive super deep into the quality and accountability information. I've already talked about the statewide accountabilities. But just want you to know that there's more information there if you'd like. So we've sort of, the Green Mountain Care Board and us have sort of talked about this and worked together. We've sort of divvied, when we think about accountability and evaluation and measurement, there's really three buckets in this model. One is that statewide accountability that we discussed. The primary care investment, the total cost of care, the quality and equity targets. Just to let you know what they're thinking, they're saying that for equality and equity measures, that the states will need at least 6 measures. So it's not a huge, number of measures, but they're very carefully placed in domains so that it's covering some different areas. And so that's what they're talking about for the quality targets at the statewide level. There's also some requirements, the last two bullets in that first box, especially that fourth one. You know, the last one talks about that there might be some flexibility. The fourth bullet, someone asked today, are there scale targets? And, you know, we had scale targets in the current model, and I think folks realized, oh, wait a minute, we can't compel self-insured involvement. We can't really compel Medicare Advantage. Gosh, we can't even compel federal employees, And so I think we, realized that, the scale targets were over-ambitious because it was literally numbers of monitors attributed to the model. They haven't said a whole lot about scale here. What they have said is that for hospitals, in year one of the model, for a state to even get through the door, 10% of Medicare fee-for-service, inpatient and outpatient service revenues have to be under global budgets in that first year. So we have to have, we would have to have hospital involvement that would represent at least 10% of those Medicare fee-for-service revenues for those inpatient and outpatient services. By year 4, it would need to be 30%. So, we have a couple of hospitals, I can think of definitely one off the top of my head, but there's probably others that one hospital could get us to that 10% level in the first year. In the second year or the fourth year, one hospital, if it was the right hospital, could get us there too. But, they're clearly trying to, understand that it's not going to be everyone. This is, the hospitals have to look at the map. They've got to look at their boards. They've got to look at their priorities. There's a lot that would go into making a decision on this. And so, that's the closest thing they come to a scale target in this model. And then similarly with payers, they are saying that by year 2, there needs to be at least one commercial plan in the model. That could be, it could be just one, it could be one self-insured plan, it could be one Medicare Advantage plan, it could be one, payer for their qualified health plan business. So, they're saying that somebody's got to be at the table by year 2 on this thing from the commercial side. So that's bucket 1. Bucket 2 is the hospital level payment, payment model measures. And so again, there's quality performance adjustments, there's that health equity improvement bonus. They need to be, they're going to be accountable for total cost of care. So there could be an adjustment there. And then, what they call effectiveness, which is really reducing unnecessary utilization. So they'll get their budget. There will just be adjustments, up or down based on some of those things. And then primary care, they're again talking about a very limited number of measures, 5. I've put that in the appendix as well. How they perform could adjust their payments up or down. And again, they're suggesting that there might be some flexibility in measure selection. I do want to note that critical access hospitals in this model have a longer glide path on some of these things, particularly if it might be a small downward adjustment, they've got a longer glide path. And then the next slide just shows the quality strategy. That as they describe it in the NOFO, it's pretty repetitive in terms of here's the 3 buckets. But I want you to see those domains that they're talking about, because that's where the measures fall into domains. Prevention and wellness, population health, mental health and substance use disorder, and then healthcare quality and utilization. And you can see the goals there. And then if you want to see what the measures are, they're in the appendix. So I'm going to stop there and turn it over to Wendy to talk about the model governance structure component of of AHEAD and then health equity.
I'm going to save my question for the end.
Well, the AHEAD model has built-in structures to ensure advancing health equity is really at the forefront of this model. Each state that's selected to participate in the AHEAD model will establish a model governance structure. That structure will have a key role in developing and monitoring health equity strategies within the model. The structure may build upon pre-existing work groups or boards and can have an advisory role. The required role is quite extensive and even quite technical in nature. I'll get into that in a little bit more detail on the next slide. But we'll note that it includes both providing input on the selection of statewide population health and quality measures and equity targets, developing the statewide health equity plan and producing annual reports on progress implementing that plan, assisting with the review of hospital health equity plans, and providing input into the use of the cooperative agreement funding that Pat had noted earlier about. Representation must include the state Medicaid and health agencies in a leadership role. That would be bringing together individuals representing patients and advocacy organizations, community-based organizations, payers, provider organizations, local tribal communities and the State Office of Rural Health, and other partners such as those whose policies influence population health. So the AHEAD model includes a number of key strategies and activities to advance health equity across multiple sectors. That model governance structure has a significant role in planning for and monitoring these activities. So the boxes on this slide depict those health equity related activities. The state, in collaboration with that model governance structure, must develop the statewide health equity plan. That's going to define and guide the model activities that are aimed at reducing disparities and improving population health in the state. CMS is going to be providing a template to states to really guide this work, but it's expected to include identified health disparities and population health focus areas, measurable goals to reduce and improve population health, evidence-based strategies to advance towards those goals that are selected, and processes to involve a wide range of stakeholders in implementation of that plan. So really including individuals who are experiencing health inequities in the current system. The statewide health equity plan must be developed by the end of that pre-implementation period and must be updated periodically. Participating hospitals in this model will be required to develop health equity plans as well. Those would detail observed disparities and identify approaches and resources they'll use to advance equitable outcomes. The model governance structure will be required to review those each year, and they will be also including some information from that into the reporting that goes into our state reporting to the federal government.
Can you give us a practical explanation of how the governance structure will relate to AHS, your role, and others, and also to the Green Mountain Care Board and to the ACO?
We are currently looking at various ways to incorporate this into a lot of the activities that we're already doing, since we're already convening a number of the required participants through our work we mentioned before, the healthcare reform work group. There are other bodies. So I'll talk a little bit more about some of the areas that we've started seeing, looking at. This is where a lot of activities happening in the health equity space today. How can we leverage and build upon those? So I don't know if I'm fully answering your question, but I think we want to be trying to really utilize a lot of the structures that we have already started collaborating very closely with the Green Mountain Care Board, Department of Health, across the partners. So then participating hospitals and primary care practices must collect and report standardized self-reported patient demographic data to CMS that can be used to monitor impacts on health disparities and patient outcomes. CMS will be providing technical assistance to providers, since this is not to be taken lightly. This is a heavy lift for them to be doing this work. And then in terms of the health-related social needs, screening and referral, those participating hospitals and primary care practices will also be requiring to screen patients and make referrals on those health-related social needs, such as housing, food, and transportation. And this is sort of what I was just speaking of it. As you're aware, the state's actively working on strategies to advance health equity in a number of areas. This really gives us an opportunity to leverage, advance, and build upon those current efforts. So as we've been learning more about the requirements and reading the NOFA, we started coordinating current activities and experts, such as the Health Equity Advisory Commission, the Vermont Department of Health and their state health assessment, state health improvement, community engagement process. What you had just heard about previously, getting lessons learned from the Act 167 community engagement to support hospital transformation efforts. The AHS Health Information Technology team and Green Mountain Care Board data team and Blueprint for Health. We know there's other activities happening in this area, but we really see a lot of opportunities within these activities to learn and advance. Just note that we also intend to leverage the extensive information, data, and expertise of these organizations to really design that model governance structure and inform its work related to health equity plans, measures, and targets, provide input on the use of the cooperative agreement funding, which I'm going to be talking about next, and efforts to ensure the model is informed by those diverse stakeholders, especially individuals who are impacted by health inequities.
Wendy, just real quick.
Yep.
And I know I'm saying something that we all know, but I feel like we have to put it out there. I think one of the big themes that's coming through on all these 167 work is provider burden. And when I look at all the things that this model may require our providers to start doing, it just has me really concerned, as I'm sure it does you.
Thank you. I think that's an important statement in thinking about where one of the areas that we're talking about is the statewide data health IT infrastructure. Are there ways as a state we can support our providers in some of this work, as well as the technical assistance that the federal government is providing? So we'll have to be collaborating closely with them on how to really bring all those various pieces together. But I agree, there's a lot of exciting work that this is moving forward, but it's not easy work. If it was, we would have already.
Because we still have to see patients.
Right.
Oh, wow.
Got that access issue.
Yeah, I mean, some of this work is being done already. There's work happening around a standardized health-related social needs or social determinants of health screening, for example. They've already been collecting some of that data from, for various purposes. But we need to attend to what's new. Think about if it isn't already happening and there's a desire to participate in the model, how can we support them?
Thank you.
So the next section, we've already spoke a bit about this, is the cooperative agreement funding. As noted earlier, it's up to $12 million, dispersed as $2 million per year over the first 5 budget periods. There's some initial funding when you really get accepted into the program, and then can get another $2 million, so that a larger amount is available during that first 18-month period. So state applicants within the response to the notice of funding opportunity must submit budgets that include activities needed to successfully establish the model. So some examples are using the funding for recruiting primary care providers and hospitals to participate, setting those statewide total cost of care growth targets and primary care investment targets, building some of that necessary infrastructure and capacity, particularly around mental health and substance use disorder treatment, supporting Medicaid and commercial payer alignment across the model. You see there's also a very extensive list of other examples that CMS is saying we can use those funds for. It is limited, but it is helpful to know that they can be used on things like state agency staff for new technologies, ways to integrate the community services referrals, bolstering health information exchange, creation of provider dashboards, supporting those population health activities, implementing screenings and referral processes, developing these different methodologies and various other aspects that align with population health improvements. I don't think we can do all of that with $12 million, however.
No, but there's also a lot of this happening.
There is.
I think about some of the FQHCs collecting data on social determinants or ACEs and our primary care docs similarly, or the question that I will like to hear an answer to at some point is how we're going to coordinate our IT across hospitals and providers, and so on and so forth.
I'll just note, as we're working on the NOFO, we're going to be really considering what are some time-limited, one-time investments that would support model implementation and transformation. And as part of that response, we'll be looking to develop a sustainability plan. So there'll be a lot of effort to be, again, looking for some of those more time-limited investments that go during this initial five-year budget period. We've talked a little bit about this throughout the presentation, so maybe I'll try to save a little bit of time on it, but this is related to the role of Medicare waivers and care delivery transformation. You've seen the slide before, but really wanted to point out that CMMI has the authority to issue Medicare waivers to test innovative payment and service delivery models. These waivers provide that operational flexibility to help participating organizations succeed under the model and support care delivery transformation. Also allows participating hospitals and primary care practices to engage with other providers across the care continuum. So here, one of the incentives for hospital participation that was noted before was to really support that care transformation with those non-hospital providers. I'll also note we had expected to see more information on what Medicare waivers would be available under this model in the notice of funding opportunity, but they've indicated that guidance is forthcoming. So we can talk a little bit about what we are hoping to see and how we've been engaging CMS to date in order to try to really see within this model those waivers that would be most useful to Vermont. So we had a work group. It convened last spring, and we noted, we really focused that discussion on what are problems that new or revised waivers could currently address. We have a number of waivers under the current all-payer model agreement. Some have been used, some have been harder to use by providers. So we learned a lot about that. We talked about those new waivers that other states have been using through other models and which ones could be of interest to Vermont. And we talked a lot about operational challenges. So some of those operational challenges that limit Medicare uptake is currently, they are currently implemented by the federal government. Are things around billing and contracting. So some waivers require physicians to contract directly with health providers. That's really challenging to have so many different contractual relationships, as well as the attribution-based eligibility, which really makes it hard for providers to understand who they could use these waivers to support within their practices. So we have been advocating for opportunities to really improve these waivers with CMMI. CMS does note, similar to we had mentioned before, it takes 18 months to make changes to payment. It's also operationally challenging for CMS to make changes to these waivers, but we're hoping to have a continued partnership on making these usable by for our providers, as well as really bringing new waivers into a model, since it's an extended model time period. We've talked about a little bit about some of these, but the technical advisory group has identified and proposed to CMMI 24 waivers that could support care delivery reform goals. The waivers include some of those waivers that we already have today, but that could use modifications, those that have been tested under those other CMMI models, and then some that were used during the public health emergency that people found really effective, including how they were operationalized. And then just the ones that have been useful and we wanted to see extended. So in doing the work of that work group, we looked at a number of goals and waivers that could help us achieve those goals. So I put some examples in here in terms of connecting Vermonters to the right care at the right place and the right time. One example is the skilled nursing facility 3-day rule waiver. So if a patient with a fall-related injury needed to access services such as skilled nursing care or assistance with ADLs and physical therapy, they could do that without having to meet that 3-day inpatient requirement. And then they could be receiving the right care at the right time and avoid those unnecessarily hospital utilizations. In terms of expanding access to services at home, an example would be the care management home visit waiver. So a waiver for care management home visits would allow someone with multiple chronic conditions to receive in-home care and avoid ED utilization or hospitalization. Improving care delivery at the end of life, that would be new to Vermont. We haven't had that waiver before, but that would allow us to really increase our utilization of hospice, which we've been lower than the national average here, and would really kind of take away that terrible choice, which people have labeled as having to choose between the use of hospice and curative life-sustaining treatment. And then enhancing access to care, especially in rural areas, through optimal use of technology. So we currently still benefit from expanded telehealth benefit enhancements that were available under the public health emergency, and Congress has extended, but those could end at the end of 2024. So we're really seeking to ensure those can continue, and we can make sure that people, especially people living in rural areas with limited transportation options, can access necessary care through e-visits and consultations.
So we're not going to spend really any time on the last two because you don't have the statewide data and health IT experts sitting in front of you right now. And, you know, the Medicaid and commercial payer alignment, I think we've spoken to in terms of what the expectations are there. So the last couple slides before the appendix are really, you know, thought it might be helpful to see a timeline in a graphic. We have, you know, covered this already, but we're basically talking about applications by March 18th. And then we're hearing that CMS will select states in May, at some point in May. And then just in case you're interested, this is what's required, particularly in the project narrative for that, you know, proposal development in response to the NOFO. Within each of those bullets, there's like a whole lot of other sub-bullets, but just like, you know, you might want to see the different areas that they want to hear us respond to in an application. So things, for example, like hospital recruitment plan, vision for primary care, transformation primary care, recruitment plan, you know, the governance structure, et cetera. So these are all areas that we'll need to respond to and be pretty significant detail, although there's a limit of 60 pages, double spaced, I think 12 point font. There are some very detailed requirements. They're like, and margins and everything else. So, it's a lot of stuff they want to hear about, but we were talking to some folks in Maryland and they're like, well, there's only so much detail we can go into in 60 pages, double spaced with 12 point font. So just thought you might want to see that. This is what we'll be working on, morning, noon, and night for the next, 100 days or so.
So we are working on it.
Yeah. Well, a lot of the work that's been done before, hospital global budget, technical advisory group, the, primary care work group, even the community transformation work, the blueprint expansion, all this stuff is going to inform that application. So that's the best we can do as an overview of this very complex model.
This is what we needed to hear, I think, to get us launched, to move ahead. And then you've added in some appendices. But certainly there's a lot of questions and a lot of discussion. You are working on the application now, and it is due February,
March 18th.
March 18th. So in the meantime, our goal in our committees collectively, and in this committee, maybe more specifically, there may be some things that we can help with in terms of our requirements. So, for example, will CMMI require participation of any or all? And you said, certain participants the second year, so we're thinking of the private insurers, and then what about participation by primary care? It sounds like we're in a good place. But what we're hearing from our primary care docs is that they are stressed out administratively. And I think that was a good question about the administration of all of this, what's going to happen. So what kind of apprehension is there right now within our primary care world? And what, if anything, can we do to help ameliorate that? So that's an important issue. Otherwise, we are going to lose. And having the payment incentives is one thing, that's good. But we were talking at lunch and Senator Cummings was bringing up the issue around primary care doc who had to sit until 10 o'clock at night or whatever time it was to complete all the data entry information about patients, and that just destroyed the practice. So this is a reality, and I'm not sure whether the application is that's not going to solve the reality. So there's some things perhaps we can do to help. Here we are. We're helpless here. We would like to help. That's one. And a part of that, I think, are the linkages, the IT linkages that are so critical in enabling folks to have access to clinical information. As you're talking about really an outcomes assessment or accountability, and that's up to the professionals. I mean, that's up to the clinical folks to think about that. But at the same time, what are the requirements for what do they have to do? What's their responsibility here? So it leads back to that whole issue around administrative load. So you may have some insight into that, but that's a concern that I have in particular. And then, so I'm just throwing out a bunch of things. So the statewide IT infrastructure is important. Data, clinical data collection, what kind? Right now we have claims database. We've asked in our bill to have all of those things integrated together so that we can look at not just claims, but clinical information all together. And then we have some barriers, of course, with private insurers who have their own set of information. So we want to improve population health. We can't remove all those people. So there's a lot there. And then there are some things that are maybe left behind in this whole process, which, obviously, but I'm looking at Sue Aronoff and I'm thinking the disabilities world, the long-term care world, what is happening with Senator Kitchell's demographic change? Not yours, Senator. I retract that comment. The people you were talking about earlier.
I'm sensitive because I'm getting older and getting infirmed.
And then finally, here's an interesting thought that I don't know if you can answer, and that is New Hampshire completing the RFP for this? Because we have a relationship with New Hampshire.
Yeah, we don't know for sure what states are involved. People are being a little cagey.
Are they?
I would say that I have not heard New Hampshire,
They haven't.
I haven't heard them, like talking about this. That doesn't mean there's not. I can tell you that, they've been having these webinars and hundreds of people have been showing up at them. I like to say that maybe 90% of them are healthcare consultants, but, they are, there's definitely a lot of interest, not only for states, but for those sub-state regions. But, to go back to the administrative burden concern, it is a concern. We're hearing it from the providers. The whole MIPS exemption thing is a concern. Collecting quality measures, it depends on what they are. When you look at that appendix, you'll see that some are claims-based measures, and those, CMS will calculate those based on the data that they get for Medicare. The clinical measures that they have in the list are ones that we are used to collecting by and large. They're ones that are in our current model. So that's fine. But we've been collecting those at the ACO level. And in this case, they're talking about more at a hospital or a practice level. And so we need to ascertain if practices are interested. The FQHCs, I think, are fairly used to doing this. But if practices are interested in joining, I think we need to evaluate. Number one, if there's flexibility, is there enough flex? Well, I'll give a concrete example. One of the measures that they're saying for the mental health and substance use disorder domain is that they want the measure to be screening for clinical depression and follow-up plan. That's a clinical measure. That's a measure where you have to get information from the health record to see if that occurred. It's one that we've used. I mean, we have it in our current model. But the question is, to encourage primary care to participate, could we sub in a claims-based mental health measure in lieu of that? Does it have to be, or could we start with a claims-based measure? There's some follow-up measures after ED use and things like that we can get from claims. So, I think those are some of the questions. Now, we don't have to have the measures in the application, thank goodness. Because we need stakeholder
have resources in order to implement.
Yeah, we need stakeholder engagement. So it's going to take some time. But by the time if we were to be selected and want to move forward, we'd have to have those measures in our state agreement, I think. And so, we got to work, we got to convene folks and see about that. But, the other thing is we're small practices here. So you got to think about small numbers too. But, but are there ways that we can ameliorate the administrative burden maybe that way? Or maybe, or can we help them so that they can collect the data and they can make sure that they're able to submit it electronically? I met with the Vital Board. I guess it was this week or last week, who knows? And that certainly there's a role there. And we've been working on that linkage of claims and clinical data for a long, long time, and some progress has been made. And there's a lot of work still to be done, but, whatever we can do to make that easier for practices, you don't want people to be having to spend all their time on this when we're worried about access to care.
Right. And we're going to lose more primary care practice.
Yeah. I mean, there's some good things in this about primary care too. So it's but you gotta balance the good with the burdensome.
So committee folks, are there questions that you would have? And then I might ask Green Mountain Care Board if you want to interject anything, since you've been listening and working on this as well. So, but we'll start. Any questions of Pat and Wendy? This has been very helpful.
I hope we haven't made your eyes glaze
Well,
up.
it's chapter 1 for a number of folks, so it's good to get started. Owen and Robin.
If the committee would like to hear from us on some of the global budget work that we've been doing, we're happy to share that. And I wanted Robin Lunge, Member Lunge, and Dr. Merman are here. And they've been spearheading the global budget development from the board perspective. So if they would like to speak.
I'm happy to answer your question from earlier, Senator Lyons, about timing, if that would be helpful.
Yeah, please.
So Robin Lunge, Green Mountain Care Board, for the record. The timing of the hospital global budget development, as Pat alluded to earlier, we've really been working on this for almost a year in terms of the stakeholder engagement. The TAG work will be wrapping up in January, and then there will be a hiatus. We're expecting to have a Medicare straw model for the hospital budget methodology. We have outlines, lots of details already, but we want to have the straw model and some modeling, hopefully in January, to be able to start to really understand some of the revenue implications. There are a lot of decision points that we as a state will need to make in order to do that modeling. So there'll be assumptions that can change over time. And then what we know from CMMI is that we would need to submit, I think Pat mentioned this earlier, a technical specification to Medicare should we want to pursue a Vermont hospital global payment methodology for Medicare by July. So that will be before we have signed a state agreement. So that's a lot of really detailed work we would need to proceed on. A little bit chicken and egg question. But this is due to their 18-month implementation timeline. So we'll continue to work through all that. And then I think the next step, we've been prioritizing Medicare. The next step would be continuing to work around a commercial payment program. We have been working with the commercial payers in the TAG. So we have some areas that we know there would likely need to be variation from a Medicare model, but we'll need to continue to develop that. But we really kind of prioritize Medicare because of the notice of funding application deadlines and such.
And I should add that Medicaid, thank you, Robin.
Yeah.
I value it. It's really great having Robin as the co-chair on that group. But Medicaid is also doing some work around what a global payments program might look like there as well. So, and they're, a good chunk of the way there with the current model, but there's definitely some way to get more revenue in for folks who aren't attributed to an ACO, for example. So.
The only other thing I think I would add is that we know that there's some areas that it would probably be beneficial for the state to pursue a model in terms of there's been strong support at the TAG for expanding beyond hospital inpatient and outpatient services to professional services at the,
The tag.
I'm sorry, the technical advisory group.
Thank you.
Where the hospital has professional services as part of their facility. So I think that's an example of an area where doing a state methodology would be helpful. We haven't gotten, as Pat said, the details of the Medicare methodology. So once we get that, we'll be able to, kind of develop a list, if you will, of areas that we might be able to negotiate something that would work better for Vermont.
But that would have to be within, how can we do that within this application process?
Yeah, so on the specific example I gave you, there are some data limitations currently, so we know that we probably would not be able to solve those issues for year one. So I think we would start with inpatient and outpatient and then work through the data issues for year two. So we're really thinking about it as a staged approach, which I think is also helpful in terms of hospitals transitioning to a new payment model to be able to kind of understand it better as we go along. So it's going to be tricky given the timing, but.
And we don't have to put the details of a state design methodology into the application for March. But as Robin said, because it takes CMS 18 months to get approval for and then change things for a 2026 start date, we would have to have a detailed methodology to them by July 1 at the latest. So there is a lot of work has been done, and we've gotten lots of excellent feedback from hospitals and others on that work group. But there is a time pressure there for sure.
Thank you.
Sure.
Anything else from the board? Committee, questions, discussion? Okay, I can't believe that. Well, there are probably more questions that will be coming up. This is a lot of information in a relatively short period of time, even.
We had 6 hours for discussion, I would have
Yes.
this.
We're going to start over tomorrow, right? But I do appreciate very much, I think we all do appreciate very much your presentation. I know you've done this before, but it's perfect for us at this point. And we do appreciate it, and appreciate the board again, just let you know. And the folks who've been working on this with you, providing the information to move forward. It's a lot of work, it's a lot of community engagement, a lot of people involved, and we're as much interested as others, as you can tell. So we'll stay engaged with this as well. And January is a time when we might have board come in again, or the TAG. So we'll have to be in communication about this. The Health Reform Oversight Committee is not an ongoing during session committee, but I think it will be helpful to have us all get together at some point to see what's happening. And then you'll be in our individual or joint committee meetings.
And you know where to find us, and
We do.
to answer questions. We have questions too, and we're just glad to provide as much information as we can. So thank you.
Thank you very much.
This is great. Thank you. Thank you all. So, Saoirse, I think we're good. I think we'll go offline. Call it